Okay, thank you everybody for your patience. Bismillahirrahmanirrahim. Welcome to the second National Mosque PCORI 2021 conference. We are excited to present this project to you. This is the second project in our series of patient-centered outcomes research. We started this quest for integrating mosque community programming with patient-centered outcomes research standards and methodologies, by adopting it and by making it a part of our health programs across the nation. In fact, you will hear quite a bit of progress that we have made in the past 2 years. And today we are marking the day with the second National Mosque PCORI conference. With me today, we have Margaret Dombrowski, who is a health professional. She works for IDPH, and she will be joining us to discuss patient-centeredness in the very first session. This conference we are exploring the theme patient-centeredness and faith communities, taking community health beyond CBPR. And in this very first session today, we are going to be talking about coming out from the platform of community health participatory research and moving towards the patient. In fact, honing in or focusing in on the patient in the communities that we have been working for the past 30 years. So this particular project was about equipping Muslims with PCORI-based action-oriented research tools. And we have 3 collaborators that came together to develop research tools to empower communities and empower not just Muslim mosque-based communities, but this is a model to empower any faith-based community to incorporate community health workers, to incorporate free clinics, and to incorporate the leaders of your community to move forward from community health participatory research platform to the patient-centered platform of patient-centered outcomes research. So with Bismillah, I begin with Margaret, the journey of understanding how ACA pushes the bar on patient-centeredness. By the way, I would request that people who are requesting CMEs or who have paid for the CMEs, please make sure that you sign the form that is attached in the documents of the agenda of this particular platform. We're all very new to the electronic platform, so we're learning together. So in your Socio platform, you will have documents there where this form link is attached. So please make sure that any session that you attend with CMEs, you sign off on that form so Imana knows that they would award you the CMEs with the paperwork and the details thereon. So let's move forward. Many of you know me, and thank you again for joining. I've been honored to be a principal investigator of this particular project, but I got to tell you that this credit goes to Dr. Padela, who mentored several of us through the previous project's journey, and we simply happen to be working in the community-based space, and that's why I just simply happened to be, fortunately, become the principal investigator. It's not by any virtue of my own. And I thank Allah subhanahu wa ta'ala, and I really thank Dr. Padela for coaching us throughout this process. Margaret, thank you very much for agreeing to do this presentation. She's been a healthcare public health professional. She works for IDPH, and has been a certified lactation consultant for about over 10 years. She's very passionate about maternal health and will be doing the community health, would be working with us with the community health education, and she has been doing community health education for several years now. So basically, we're going to be talking about, and with this, I want to turn this presentation over to Margaret, we would be doing a dialogue to see how we explore this together. Go ahead, Margaret, please. And if you'd like to add any words about your introduction or about this process, please go ahead and do that.
Thank you for having me. I think you did a good job of describing my journey. This started as a class project in my Master of Public Health, my last class. So this is just an extension of that, and I am grateful for this opportunity to present to your organization. Like Fatima said, I'm going to be talking about PCORI and how it affects the patients that you serve. So the main theme that is, how does the Affordable Care Act push the bar in favor of patient-centeredness? This was a really interesting project for me to work on because, like Fatima told me, a lot of healthcare professionals still, even after the amount of years that this has been in play, are so unaware of it. And I was one of those. I was totally unaware of PCORI. So now I am informed, and I want to go forward and push this agenda and be a part of it in some way. So our agenda for this presentation, we're going to examine how the ACA affected us both at the individual and the community level. And we're going to start our journey from the grassroots level, and we'll go to the big picture, and it will help us prepare for the next level of complexity that you're going to see with the other presenters throughout the symposium. Okay, moving on.
So basically, we're going to be talking about George. Do you want to tell us a little bit about George, Margaret? You have known him for some years now.
I do. This is my buddy, George. George is now 64 years old. He came to Chicago from Armenia 14 years ago for the graduation ceremony of his son, and he has not left since. He is fortunate to be a green card holder for the last 5 years. But he is not a citizen, and he is a hardworking man working to support his family, which consists of his wife, and he has one child under 19, and he works as a truck driver. So George's healthcare journey. So let's look at what has happened since George has arrived in the U.S. So in 2007, George came to the U.S. and he landed in Cook County. About a year later, he went to the Cook County ER for care. And then he returned to the same ER for follow-up care for diabetes. A couple years later, he developed high blood pressure and was offered to join a community-based participatory research study by the doctor that was measuring outcomes in Cook County that he was getting care from. 3 years later, George's son moved to Will County, which is a more rural area of Chicagoland, and George had to move with him. And as a result of moving to Will County, he loses his health care benefits. So when George arrived in the US, the state of the healthcare system in the US was large and pretty fragmented. There are several major factors at play. We had the electronic health record system in place. HIPAA compliance, the Patient Protection Act, was also in place. We did have a robust research and development environment. Medicaid and Medicare were in place, but as a non-resident, George did not have access to these things. There were major accreditation bodies looking at quality, JCO, CAPS, NCQA, AHRQ, etc. And also community-based participatory research was in play as an approach to research to address communities' health disparities. He came to this country that spends the most in healthcare in the world, but unfortunately, he didn't have a lot of access. So the form of research that George had the opportunity to participate in was called community-based participatory research, or CBPR. CBPR is an approach to research. It is a way to involve collective, reflective, and systematic inquiry. It is a way to engage researchers in the community as equal partners. It is a way to educate and improve practice with social change. The emphasis of CBPR is on partnering with communities, and it involves active involvement of community members, organizational representatives, etc. It has been practiced since the 1990s, but it does not have a history of strong collaboration. But one of the biggest pieces that CBPR did was it really brought to light the social determinants of health.
I agree, and that's really was the highlight and the contribution that CBPR made. In fact, what happened was back in 2014, there was a county health ranking model by Robert Wood Johnson Foundation, but let me take a step back. I got to thank one more person here with me. And as I go around, I keep thanking people because I think they have contributed so much to my understanding in this project. Dr. Rebecca Johnson actually coached me on a lot of these health determinants of health and how they factor in, and the community-based participatory research and how deep the roots are for community health work in that discipline. So I really thank you, Dr. Rebecca, for the past 1 year. She has been working with me in developing the community health worker discipline, and it's been a wonderful journey. So with that pleasure, I actually introduced this concept to you, and it's a pretty deep concept. So think about it, that when we think of healthcare, we think of George, for example. He was thinking, he has diabetes and now he needs to go to the doctor, and the doctor is the one that's going to take care of all of his healthcare. However, that clinical portion is really 20% of what George is going to get from that hospital or from the doctor. The rest, 70% of health inequities are actually impacted by healthy behaviors, social and economic factors. I shouldn't say health inequities for George, but those are the health factors where George is being impacted with. So this particular model came from Robert Wood Johnson Foundation, and they literally laid down the ground saying that this is what's happening, and we really need to be in tune with the social factors as much as we are in tune with the clinical factors. Now, that is why I'm saying that the patient-centered research is very new in our era, and we've just born, I think.
Mm-hmm.
So let's see.
I'd like to add on the social determinants of health a little bit. I have a bachelor's degree in maternal and child health, but it wasn't until my Master of Public Health degree program where I even really heard of what social determinants of health were. And particularly the class that I did this initial presentation in was really focused on the social determinants of health. And it is, I think, for anyone working in the field of social health, it is a necessary field that you need to understand, and you need to be able to look at all health problems through the lens of social determinants of health to be able to fully understand and make a difference. So, it's huge. And like it says here, 70% of those health inequities are affected by some of these social determinants of health. And without understanding that, you can't ever really get to the root cause and make a difference. So going back to CBPR, it's an approach. It is a way to do research. Its focus is community. It brings community members together. It works on knowledge of the community, the health problems, how to improve the care based on impact or input from the community, how to disseminate the findings with impact or with the information from the community. But you know, how is this going to affect George?
Yeah, I was just going to ask. So where's George in community-based participatory research? How is he is the one? How are we giving him what he needs? What are the things that matters to him? It may matter to the community in general, but it may not matter to him.
Right.
And that's the difference between patient-centeredness and community-based participatory package. So really, if you think from George's perspective, you know, George has two basic things that is going on with respect to his healthcare package. He has that clinical component where that is actually a package with doctors, a specialist, lab work, diagnostics. And then he has this prevention side that he really needs to keep up with. Because it's a chronic disease, he needs to understand how he manages his healthcare on a day-to-day basis. And what is it that's working for him and what's that's not working for him. That whole area is still relatively new. And to top everything, the environment and the culture that we live in keeps changing and really changes very rapidly and fast for two main reasons. One of them, yes, we have a lot of research and development that brings about new treatments and new protocols to light. The other thing is that the technology, it has access to many different things, and we are being impacted by food, by what we eat, by where we are, by things that we do, by things that we don't do, by the products we use. So all of those factors actually matters in our chronic care management. So let me just take a step back and let's see how that all means with respect to ACA, and how does ACA wants to, or how does ACA's legislature can help what all of this is going to mean for George. And ACA was, as we know, we covered quite a bit pre-ACA's work before 2010, and ACA becomes the law. That's my favorite picture, by the way. And then George moved to 2013 in Will County. You know, good for him, because 2013 October is when Marketplace opened up. And because ACA became the law, ACA actually had three main components. We'll go over that in a little bit. But in 2013, healthcare.gov opened up the website, which has many different health insurances online, and people, depending upon where they lived, what their residency status was, whether they were whether they were citizens or they were green card holders, they were able to apply on healthcare.gov. And even to this day, it's pretty much in place and it's very active. About over 20 million people have already received healthcare coverage from that. Back when ACA passed in 2010, about 50 million people out of 350 million total population were uninsured. So it was 1 in 7 Americans.
Yeah,
that was 1 in 7 Americans that was uninsured. And in fact, somehow George was actually in that category. But because Cook County takes care of its own residents, it's a sanctuary city. Don't forget that. So it took care of George. However, when he moved to Will County, he lost it. But to his rescue, ACA was there. And PCORI was actually also founded back into 2010. Let's examine a few things, what happened with the inception of ACA and how can ACA help George. So I told you about the two aspects of healthcare coverage that George needs to have, right, Margaret? It was one of them is clinical, and the other thing was chronic care management. Now, with these two things, he's actually getting two main gaps. And the two main gaps are that some medications worked while others did not. And so he needs to understand how his clinical care is going to work. And then he needs to have chronic care management decision making. So he needs to know what his treatment options are. What are some of the things that the research bodies can help him with? So he needs to have research that can help him comparing the effectiveness of the drugs or the treatments. And he also needs to have some of the other community resources where he can make informed decisions. For example, there are some treatments or some diabetic chronic disease management programs that are there that mainly cater to immigrant population, or because they bring in that the element of culture and language in there. And the other programs may not be so much appealing because they may not even cater to the way George eats.
Right.
So he's basically he needs to focus on two things: the effectiveness of his clinical treatments, and he needs to have some knowledge to make informed decisions. And those are it looks very simple, but we actually had to put, we meaning healthcare, the people who serve the body of knowledge for healthcare systems, need to put solutions in place. And these solutions are actually, turns out to be billions of dollars. And that's where the community engagement research and the comparative effectiveness research comes in.
Sure.
So ACA literally had to put all these things in place and establish the agents of change in order to develop that momentum that would change the culture. So these are some of the very basic that I'm going to go over that were established as agents of change by ACA. We see CMS, we see Medicare in here, we see National Institute of Health, we see CDC, National Center for Disease Control, and AHRQ, which is Agency for Health Research and Quality, and that actually reports on the compliance numbers. It reports on the health of our community. So eventually what comes out of AHRQ is the final result of how we are doing as society when it comes to healthcare. One of the other things I will got to mention that the nonprofit health domain remains independent. And what that means is that the insurance industry, it is still independent. There are a lot of laws in place for their compliance, yet they have their own, they are independent in the sense that they comply, but they can also run their own their own business models. So there's a lot of room within ACA to keep the two sides, the government for-profit and the not-for-profit sectors, balanced. And this is really why ACA is politicized to this extent. But you know what? This is capitalistic society. Healthcare is capitalistic in this country. No one can dictate anybody what to do. And yet the balance is the beauty. But everyone needs to know what's happening to them. And that's where we come in, because we promote what needs to what do you need to know to make informed decisions.
That's right. That's right.
So some of these are just 4 new concepts that I'm going to take out from ACA and pass on in the session. And it's one of the concept is NCATs, PCORI, ACOs, and PPRNs. All of these work from our cognitive levels, understanding and cognitive levels, all the way to how the AHRQ reports on healthcare outcomes. And bear with me, these are just 4 concepts. So let me tell you how exactly that works. The Translational Sciences is the body of knowledge that's coming up under NIH, right there, the Consolidated Appropriations Act. And the Translational Sciences is where research is translated into my understanding, Margaret's understanding, and George's understanding. Patient-centered outcomes research. Now, patient-centered outcomes research is really, we're going to go over a little bit in detail about that, but it's the methodology. It takes the approach of community-based, moves it into the methods domain. So it has, when you talk about methodology, you talk about these standards like ISO 9000 or ISO 2000, and ISO, and then there's JCO methodology. So these are compliance standards, and when you talk about the standards, you can measure them, right? So that's the beauty of PCORI. Accountable care organizations. You have heard about a lot of these hospitals were being sold because what's happening is that the hospital systems are now becoming hubs for accountable care organizations. The accountable care organization is accountable for taking care of the community health in that zip code area. That's why zip codes are important. Where people reside, that's important. People residency statuses are important because the ACA factors in a lot of the health disparities within its legislation. And then you have patient-powered research networks. These are the IT, the healthcare information technology infrastructure that ACA has promoted, where all of the details from my health and my social determinants are going into these patient-powered databases. And so when I go to a social work, the data eventually bakes it. Now, this is de-identifiable. They don't know exactly who Fatima Mirza is, but they know that there is a person who may be impacted by maybe this particular kind of treatment. And that's the power of patient-powered research networks. So it can hone in on patient if it needs to, yet it is capable of delivering results at the community level. So we're dealing with a very powerful piece of legislature that I hear about people repealing it. It's I don't know what world they are living in. They must not have seen this slide.
Right.
Anyways, let's move on. So now from these four concepts, I'm going to go further down to nailing into simply two concepts that affect George, that affect me as Fatima Mirza, that affect Margaret at our level. And those are concepts that how do I understand things? And it's that translation is happening in my head. It's a cognitive process. I need to translate, is this food really impacting me? Is this the medication effect on my end, or did I do something wrong or right to trigger my symptom cycle? So those are the things that work at the levels where we have our own healthcare gaps. And with George has two main gaps. Some medications work for him, and he's also trying to see how he could relate to the community-based programs that are there. So the NIH is helping him work with the translational process. That's the clinical research that we're talking about. The translation process also talks about the community-based research or the patient-centered research. And that's what we would see with patient-centered outcomes research methodology. And PCORI has two arms. It has the comparative effectiveness research arm, and then it has the engagement resources for informed decision arm. It actually funds two different types of research. So this particular project that we have embarked on, this is our engagement project. We are translating these complex medical or clinical terms, concepts into our own heads. We're thinking, how does it work for Fatima? And how can I help the next person or my family member help with these concepts? And you know what? This is almost like wildfire, where one stick burns the next stick. So that's how engagement works. Let's move on.
So
to you. Go ahead.
We'll dive in and tell you exactly what PCOR is. So the mission statement of PCORI is that the primary goal of PCOR is to improve the health of all citizens by providing patients, their advocates and caregivers, healthcare professionals, policymakers, payers, the government, and other health agencies with evidence-based information they can use to make informed health decisions. What that means on a more basic level is that they focus on understanding the choices patients face. They align that research and questions and methods with the patient needs, and they provide the patients and the providers with information for better outcomes. And then more broadly, PCOR is research done differently. I think that's probably the best way to summarize it. It's research done differently. The ACA recognized that we needed more than just some community involvement. We needed more than just comparative effective research. We needed to bring that other piece in of true meaningful engagement in order to reach these outcomes.
Absolutely. And thank you. Yeah, exactly. And that's really what the essence is. It's research done differently. And we don't know where it would take us. It's a journey. And as we delve into the translational approach, we discover more and more. And it's just it's just a beautiful journey. In fact, as we talked about, this is a translational is a cognitive process. It's not a learning process. This is how NIH defines it. It says translational science is the field of investigation focused on understanding, not learning, understanding the scientific and operational principles. So you can learn, but we learn and we can do the test, but that's not the understanding.
Right. Understanding is the key piece there.
Exactly. And then from understanding, it has to, in order to adopt something that we understand, it has to go into our go at the cognitive level for us in order to practice that. So adoption is also a cognitive process. So this is how the definite, go ahead, Margaret.
Oh, I was going to, I'm sorry, go ahead. You go ahead on here.
Okay. So again, translation is this is how the NIH is look at how the logo is for translational sciences. It has the basic sciences, clinical sciences, the step 1 and step 2. It has a community-based research aspect to it, and then the dissemination aspect in it. But at the core of it, it's the patient. What matters to the patient? And the adoption of this process across all stakeholder sectors is equally necessary to bring everyone on the same page of the health equity. And that's really, that's the core of it. When talking about being on the same page, this is what it is. You see that logo, you see that the patient in the center. We all need to be at the same page.
Definitely, definitely. So going back to George, I think it's really important to recognize how PCORI or PCOR affects health equity and really considers the social determinants of health and how it particularly affects George. I have a couple quotes here that I think are really, really powerful. This first one is from a 2013 study about engaging hard to reach patients through PCOR. And it says, eliciting the perspectives of diverse populations on health-related questions, not only from those who are convenient to recruit, is integral to the success of patient-centered outcomes research. And I think George is a really good example of a patient who is probably not convenient to recruit, but as we saw in his experience with CBPR, it wasn't applicable. He didn't relate to the recommendations. He didn't relate to what the other people were saying. So it ended up being rather useless for him. So from the PCOR methodology, it really takes into account his specific characteristics, his specific needs, and how to apply it to this specific person who is probably a hard to recruit patient. Another couple of quotes here that I have that I think are really important and really speak to the health equity piece of it is that PCOR symbolizes a new era in which the most important stakeholder, who is the patient, is accorded a key role in research. And then again, from that 2013 article, within the next decade, minorities will outnumber non-Hispanic whites in the US. Therefore, more evidence regarding minorities and hard-to-reach patients will become even more critical for improving the health of the nation. So moving on, speaking about reaching hard-to-reach patients, there was a study in 2011, on the next slide, Fatima. There was a study in 2011 by the University of Maryland researchers that looked at methods for including hard-to-reach patients in the design, implementation, and dissemination of research. This study consisted of focus groups and interviews with a total of 95 patients, 65 caregivers, patients, physicians, etc. And the study revealed 5 key themes for engaging and ensuring representation of the hard-to-reach patients. And they included partnering with people, just a variety of people from the actual community that you're trying to reach, such as community leaders, mayor of the block, employers, support groups, meeting in public and private places. This was really important because these hard-to-reach individuals may only be able to locate them at maybe a laundromat or a senior citizen community center, or even in some of these hard-to-reach patients, they may be in more semi-private places such as emergency rooms or community clinics, or even shelters. Using a variety of media, it's really important to understand what your audience is for the particular community. Use methods to ensure that patient understands the pertinent issues. This is really important, particularly when speaking to non-native patients. You need to make sure that you're translating that information in a way that makes sense to them from their cultural and their language standpoint. And also using data to identify issues important to hard-to-reach patients. I thought this was really important. A particular thing that they addressed was, it's important to understand what the needs of the community are, but also you need to understand where those individual patients are spending their money and what they need help, whether or not they need help paying bills and where they need help specifically, and like, for instance, in George's case, let's say one of the reasons he's having trouble with this medication is because it's expensive, but he doesn't communicate that. He's not taking it. He appears to be non-compliant. PCORI is the kind of research methodology that can get down to that and understand specifically why it is that he's not taking this medication, if it is a financial issue, and helping him to address that specific issue.
And really, it's great that you summarized it, how these studies have actually are reaching hard-to-reach patients. And this is the key here, because that's the reason why this is the second national PCORI conference, and it talks about patient engagement and patient-centeredness through faith communities. Because the faith community places are the places where you would find patients in their comfortable zones, where they are able to listen and they are in the receptive mode. Remember, we were talking about the translation process. So if you catch somebody at a supermarket or even at a doctor's office where they are too in tune with their medications, they may not be listening about what is in their kitchen pantry or what is in their spice rack. You'd catch them at a mosque or at a synagogue or at a church, and they are more receptive. They are thinking in terms of, what is my lifestyle like? And they are more open to communication in those places. So faith communities play a very important role in engagements. And that's part of the reason why PCORI is making an additional effort in order to create this culture of engagement across the entire healthcare system. They are going to these places where they can reach patients that are very hard to reach, because in fact, America is made up of the different types of immigrants that are hard to reach.
Sure.
And these minorities putting together is actually a majority.
Mm-hmm.
So we need to understand the culture and the societies and the communities we live in, and each pocket is very unique in its own ways. In fact, PCORI's methods have been so influential, and that it has already started a movement at the federal level. So we see that the FDA models advisory committee after PCORI panel. And the PCORI's rubric influences the Center for Medicare Medicaid Services for engaging patients. So if you look at this, the slide a little bit, and for those of you who are actually have a small window, if you're not looking at the whole screen, this would be hard to read. So let me read it to you. Recent best practices identifies for partnering with patients and caregivers, including adapting principles from PCORI, person-family engagement framework. We're going to go a little bit about these 5 principles, but these are very powerful principles. So when they talked about PCORI being methodology, it actually has covered every single step of the way, from values to principles to frameworks to models, and essentially outcome measures at the end, as to how each step of the way our thinking actually works to contribute towards well-being for our own communities and ourselves.
I want to add one thing. I think that's really key to the reaching the patients in the faith-based communities is there's a level of trust there that you're able to, get in and actually, disseminate the information, because it is coming at a level, at a place of trust where, in a community, a more general community setting, or like you said, the grocery store, you may not be able to do that.
Yeah, absolutely. And going back to PCORI's engagement rubric and the 5 principles, we would be actually exploring these principles throughout these 2 days and how they actually play a role in the translation process as to how we understand it to how we put it into practice. And that's adopting these principles. So PCORI methodology, I just want to highlight that there is a methodology book. Every one of us can find it. And I just want to add that after the presentations and after the conference is over tomorrow evening, the platform will be available for up to a year. And we would be hosting all of these documents, all of these PowerPoint presentations on that platform, and also on our own website. So anyone can access these, and they can access your references on there too.
Great.
So come to that. How can performing PCOR help George?
That's a good question.
Yep.
Well, these 5 engagement principles that you just discussed are going to be huge for him. The patient-centered standards as specific in PCOR methodology, addressing what are his expectations, what are his options, what are his outcomes, and his specific decisions are huge. One of the things that I think is really amazing with the PCOR, you say that it's a methodology, so we have standards, we have a way to measure, but the other piece of it is that there's a legal element to it. In order to be able to perform this patient-centered outcomes research, there are elements that are required to be included by law, and that helps to raise the bar and ensure that those things are happening, which is going to protect our George and help him have better outcomes.
Yeah. So do you think that the performing PCOR would better address social determinants of health?
Oh, definitely. Definitely. Addressing it actively engages the community. It goes and reaches those patients within their social determinants of health, within the community that they live in, and it gives them a voice. It gives a voice to the at-risk populations and the populations that are not generally included into research. I think another really important piece of it is that generally the PCOR cycle is a little bit shorter than in CBPR, and it allows the findings to get back into the community a lot quicker. One of the things, maybe you can give your example of when you were working in research and how many years it was taking for the findings to get back, and how discouraging that could be, and how PCOR addresses that.
And I'll tell you, PCOR really builds capacity at the community level. And we, in the next few hours and tomorrow, we will explore how community-based organizations can build capacity. And really, I would promote the next session we have with Dr. Rebecca Johnson, who has actually been my mentor for this past year on the asset-based approach and work and doing the community health work as training community health workers for the community and in the community. And she would be discussing that asset-based approach along with PCOR methodology and how we can utilize it. After that, this afternoon session is with Dr. Vallecos. And us, we would be talking about free clinics. So from this project, actually, we developed a free clinic patient-centered model. And that model, and this is the beauty of the PCOR principles, by the way. We have been trying to get the clinic started for the past 4 years, and I had not applied PCOR principles in the past. With this project, I had a chance to delve deeper into the principles and translate those principles into my behavior. And guess what? This free clinic was up and running in 3 months.
That's amazing.
I just couldn't believe it. And I just rode on the momentum that was generated by the principles. And I'll tell you this, unless you adopt the principles cognitively, you won't feel the difference. So we're going to be discussing that. And then tomorrow we would actually in the morning, we would hear from other PCOR leaders who have been doing wonderful things in their communities. We would have Dr. Padela describing at length how mosque communities have put together a framework for doing PCOR programming in our communities. And then we would come to the Leaders Roundtable discussion, incorporating PCOR's national priorities with the ongoing programming in the faith communities. And how can we do that effectively? And we would be discussing that, not with anybody else, but with a PCOR program officer. So I am really looking forward towards the end of this conference already, but it would be, inshallah, looking forward to having a delight.
That's great.
I just want to leave with a note that these are the 5 national health priorities that is in a proposed mode right now, but PCORI would be adopting it very soon. It looks like the comment period is over, and they have gone back to the table to modify and to finalize things. But this is what's coming our way to move forward, increasing evidence for existing intervention. So how George can be helped. And George is the one who's going to give the feedback into this evidence. Enhancing infrastructure to accelerate patient outcomes. Enhancing infrastructure, meaning as community-based organizations, capacity building, we are being a part of it. Advancing the science of dissemination. This in one-year project is a beautiful example of the dissemination of the Mosque PCOR toolkit, which we developed in the previous project. And we took a step further by adopting PCOR principles to disseminate that the knowledge and the body of knowledge and information that we generated in the previous one. And in return, we achieve health equity. That's the goal. And so that and accelerate progress towards integrated learning health systems. And these learning health systems are going to be the key to move our understanding from one stage to another stage. So I'm really looking forward to it. The need of our time is to cultivate a community that is ready for outcomes research. And this is a very minor effort and a step towards that one goal that we all have. So I really thank you for you to join with us today. And we have a few minutes for Q&A. Margaret and I are here, but I got to tell you this, the future is yours. Engage. And save the date, September 15th and 16th, in 2 years, we're going to convene back, more than likely, on the virtual platform to see what have we done in the next 2 years. I'm really excited to embark on this journey. Thank you, Margaret, for your time. And Andrew, I really appreciate it.
Thank you for having me.
I just remember I promised Q&A. Sorry. Okay, so are there any questions? I see that. Are there any questions that we can have? Let me move up to the slide as to what to bring in perspective what we're doing. Any questions that I can take from other people or Margaret can take? You know, I am unable to see my...
I see that Dr. Johnson gave us a virtual high five. What a great
thank you.
start.
Yeah, you're seeing
I don't see any questions. I don't see any questions. I think we probably just, got everyone excited for what's to come because there's a lot more exciting information coming after us.
Oh, I see that. And I am hoping that the attendees have, if whoever needed to get their CMEs credits, please make sure that you fill out the form. Asna also placed that in the chat. Thank you. There's also on the platform, you would, on the left side, there is a menu bar where quite a few links are provided there. And you can explore those links. We have exhibits available. We also have our sponsors and the partners pages in there. We actually also have a presentation we would be relaying in between the sessions. This particular session goes directly into Dr. Rebecca Johnson's session, but after her session there is a break time, and I would encourage everyone to have their screens on because we have quite a bit of information to share. We would be going over the dedication, and there would be today is the Friday, so Friday prayers means a lot for mosque communities and for Muslims. So we actually make a special supplications after the prayer, and we did have another welcome address session before our session, but that the link was, you had to go to that link in order to attend that session. So we weren't quite set up for that, and I guess that happened, but you may not have joined that session. However, we would be streaming live throughout the day, and if you want to keep this on in the background to see what's happening, by all means you would be able to do that. Just for the afternoon, we would be, after the prayers, we would be doing the supplications and the dedication of the project. That's a surprise, and there's a little presentation that goes along with it, so I'm looking forward to that. And then we would go for the free clinic session starting at 2:30. So hopefully we would end up with a nice break time also, and along with some educational time in the afternoon.
It looks like we do have a couple of questions.
Okay.
Dr. Johnson is asking me, what is the one thing that I will be taking forward? I think, well, my passion is maternal and child health, particularly in the space of health equity. I have a real gut drive to try to figure out how to solve the infant mortality disparities that exist between Black infants and non-Black infants, particularly in Chicago. For those of you that don't know, Black infants die at a rate of 3 times that of non-Black infants. And they are also at greater risk for a lot of the morbidities and mortalities that can be solved or improved by breastfeeding. And you may also know or not know that breastfeeding is, the rates are significantly lower in Black mothers and infants. So I have written a couple of pieces about trying to figure out how to solve this. And I wonder now, after everything I've learned about PCOR, if there's some way someone can, or if I can be involved in doing some sort of PCOR study to understand what it is that is preventing Black mothers from breastfeeding at the rates that non-Black mothers do, because this could, really save a lot of infants' lives, potentially. So I would love to explore that further. That's what I'll take forward.
Wow, a research question. Man, you'll be going far, Margaret.
I hope so. I got a lot of ideas. I just need some collaboration, and that's what I need.
Absolutely. I have one more question. How do you see the future of CBPR? CBPR is always going to be there because it is the platform that gave birth to patient-centeredness. So I see that was an approach. And as human race, we develop an understanding, we move forward, and from that understanding, we move forward, and from that, we move forward. So from CBPR, we have come out as having the understanding of patient-centeredness. And I'm very sure from patient-centeredness, we're going to move on to the outcome measures understanding, because that leads into it. And from outcome measures, we don't know where we would lead into. It is up to the next generations to decide, and the next wave of challenges, in fact, would determines it's interesting that those questions determine their own answers. So the challenges will determine their own solutions. So I'm very hopeful that we would, as human race, we would definitely have. We will figure that out as we move forward. So I'm going to actually log myself out because we are now going into the next session, and there is a different link for that session. So hopefully we can leave and then come back, meet again. Thank you.
Thank you so much.
Thank you, Margaret, and thank you, everybody, for joining us.